But when we were doing the study, I mean, because it was the first proper modern study of oxygen in cluster headache, we didn't want to get it wrong. It would have been really terrible to have to come to you and tell you it didn't work. That would have been really awful. Because I'd made some, technical cock-up in the way we'd done the arrangement, so we were careful about doing that. Oxygen is nice in this way because it's really easy to blind. It's hard, as far as I can tell, it's impossible to tell whether you're breathing air or breathing oxygen, so that makes work very well. Even the cranial autonomic symptoms were reduced. Sadly is not the word probably. I was a little surprised when we went to the CMS, the Medicare people, and had the discussion around this, that while they acknowledged the study was okay, thanks very much, they were a bit concerned that we didn't have enough Medicare beneficiaries in the study. So the Medicare people in the US want this study repeated with Medicare beneficiaries. It is what it is. I mean, you can't, there's some groups you can't argue with. So it's going to have to be done. They'll pay for the supply of the oxygen, interestingly enough, because they realise that this is a reasonable thing to do. But it's going to need to be done. We need to look for people who are Medicare beneficiaries a little bit to enrich the study. It's something we'll probably need to do with your group in terms of its spread on the web to be able to access enough patients to do this, because we need another study to get this on Medicare in this country. But at least we know lots about it. If you know something like the placebo response, it's easy to know how to do something called powering. So it's relatively easy to calculate how many patients you need to do this study in this other population of people, and be reasonably sure that we wouldn't miss a result if a result was there. So don't be surprised if there's an approach to do a study with cluster headache and oxygen in the US in the next 6 months or so, because it needs to be done, and without doing it, we're just not going to get anywhere with on the government side. Upside is that if we do a study to their standards, which is not hard, this study's at that standard, then probably get it listed, which would be really quite helpful, I think. Oh, just to show you that we started to take an interest in how oxygen works, which is just as interesting as the fact that it works. Desperately, and if you find something that works, perhaps the more interesting question is how. So we've developed an animal model of some of the symptomatology, you might say, around cluster. Obviously animals don't have cluster headache. But you can turn on pain, you can anaesthetise them, and you can turn on pain systems by stimulating structures that would be painful in humans, so the covering of the brain, the dura mater. And you can actually, skip to the next slide, you can actually, in rats, you can measure the lacrimal gland blood flow as a way of looking at a surrogate for tearing, if you want. So you're not looking for the animals tearing, you're looking for changes in this blood flow. And you can see that with this area we're stimulating in the brain, you get these nice spikes, and that's the lacrimal gland blood flow jumping up like that with the stimulation. And you can show that with oxygen you can inhibit that, and you can find some nerve cells in the brain oxygen will turn off, stimulated by pain structures. The detail is not so important, but to say that this is the first model in an experimental of the effect of what oxygen does, and it's an effect that triptans can't quite model as explicitly as the oxygen does. And on the other side of it, you can show that one of the effects of triptans on another response that we've shown doesn't happen with oxygen. So you can start to dissect the two out. What's the use of that? If you want to develop new treatments, but completely different ones you hadn't thought of at all, that are totally unrelated to the current chemicals we have, and totally this is totally novel in terms of therapies, you need some way of filtering your ideas. Now, you could just give everything to people. I'm not sure that's a good idea. I think a proper way of doing this is to try and understand the mechanisms in the laboratory, experimental animals, anaesthetised animals that we're using, and then take the things that are promising forward into human study. I realise some people think that that's a crazy idea because they don't like the idea of doing experimental work. But I think there's a case to be made for responsible use of experimental work, to understand what it is that's reasonable to take forward into humans. And I understand that's a little controversial in some areas, but I'm going to say that I think it's important, and that in the context of cluster headache, it's important in many other contexts that you can have in medical research. And just to show you that this has started to happen. It's the first model for doing it. Neurostimulation is another area you would be familiar with a little bit, which has changed quite a lot the vista of cluster headache. It's thousands of patients don't have these stimulants, but it's been quite an interesting learning curve around the various stimulating things. The first thing, which is probably almost more interesting than anything else, the Italians did the first stimulation on a patient with cluster headache, Sony. They took the coordinates from the imaging work that we'd done, put an electrode in the brain, and turned it off this person with chronic cluster headache, which is great. And this doesn't work for everybody. About 2/3 of patients get a response. And that's really weird when you think about it, that some people, you put the electrode in the same area, and some patients turns the attack off, and some patients just make a blind bit of difference. Some part of the key clue there that we haven't quite grasped yet. What is interesting about this area of the brain, it was been known for a long time that the same area of the brain that was targeted for psychosurgery. So there's in some parts of the world, if you're really completely mad and have this acting out behaviour where you sort of strangle chickens and cut yourself, no, seriously, I think you could call it crazy behaviour, and I won't describe it all because we're on public broadcast, and if I said all the things I know these people do, I'd probably be taken out what had happened, I'd probably have to repeat my political correctness training at university. I already did my 2 hours for this 2 years of that. I don't want to do that again, so I just won't say any more or get myself in trouble already. So, at any rate, for this psychosurgery, what the surgeons recognised was that when I was talking to a neurosurgeon about this once, and he jumped up, who'd done the psychosurgery, showed me this book with this Sano area in it, and pointed out that when you take people, when they're having this psychosurgery and you put the electrodes in and you turn the electrodes on, so these aren't people with cluster headache, these are people who are crazy, and you put the electrode and you turn them on, then very quickly what the surgeons realised was the patients became restless, agitated, and they wanted to move about. Now that impressed the neurosurgeons because if you imagine if you're doing brain surgery, the last thing you want is a patient who wants to get up and move about. Because it's very unhelpful if you're doing brain surgery and people are trying to move about. So the anaesthetising and stop that. What's quite remarkable is that we came to this area from brain imaging. You put a stimulator in there and you can alter the disease in many patients. And remarkably, if you stimulate the area in other people, the only ones that have been tested, of course, these people having psychosurgery, then you can get them to reproduce the same sort of behaviour as the cluster patient had during an attack. It tells you that this area must be in some way fundamental to the disorder and also fundamental to even some of the behavioural things that happen around the disorder, which is quite unique when you think about understanding bits of the brain that make you behave in certain types of ways. Occipital nerve stimulation is the next thing that was developed. And we became quite interested in this because I've been interested in how the occipital nerve impacted on head pain for years. And in the early days of deep brain stimulation, one of the Belgian group had a patient die, which was rather a turn off. So we directed our efforts into occipital nerve stimulation because you don't die from it. That seemed like a practical thing. This is the first of the patients that we reported out. Broadly speaking, the results are about the same. About 2/3 of people who have these occipital nerve stimulators